All right. Well, it looks like we're having some attendees start to roll into the room, so I'll get started. My name is Dr. Siegel. I'm a foregut surgeon in Florida, and I'm part of the American Foregut Society, working on the webinar team. For those of you who've seen our previous webinars, we really appreciate the attendance. We've had some absolutely amazing speakers for various topics throughout the year. The next topic that we're rolling into is gastroparesis. And again, this will be split into two different subsections. The first one tonight on diagnostics, and then to follow next month on therapeutics. So we have a fantastic panel tonight. We'll introduce them one at a time. The format will be about 15-20 minutes or so per speaker, and then Q&A at the end. If you have any itching questions, there are questions that you want to get out to the chat right away, please feel free to do so. On Zoom, I would request that the Q&As get put into the Q&A section of the Zoom instead of the chat feature. That way the attendees can the presenters can respond immediately, or you can save your questions to the end. So any questions, go to the Q&A tab. So I'd like to go ahead and introduce our first speaker. Our first speaker is Gottfried Blackmore at Stanford University. Quick bio: he completed his medical school and residency at Cornell, and this was followed by a fellowship at Stanford University in 2018. He also received a PhD from Rockefeller University studying neuroimmunology and neuroendocrinology in 2007. He's had 2 clinical trials, including vagal nerve stimulation for gastroparesis, as well as the GI challenge study for gastroparesis patients. He's had numerous publications in the field and has been cited well over 1,500 times. With his strong scientific background, he applies his knowledge to treat patients with gastroparesis, as well as other functional motility disorders via translational research. It's his personal goal to forward the field and improve both the diagnostics and treatment modalities for motility disorders. Tonight, he'll be discussing gastroparesis phenotyping using stomach tissue biopsies. So, Andres, take it away.
Thank you very much, Steve. Can you see my slides?
Looks good.
Well, it's an honor to be here. And as Steve mentioned, I'll be discussing gastroparesis phenotyping using stomach tissue biopsies. This is mostly focused on deep tissue biopsies, but I'll be discussing some other types. I have no disclosures to share tonight. As an outline for my presentation, I'll give a brief overview of gastroparesis and then discuss the knowledge we've gained from stomach deep tissue biopsies. And throughout, I'll be trying to discuss what the diagnostic and clinical value of tissue biopsies has been. At the end, I'll discuss some alternate biopsy approaches, which are up and coming and I've been working on. And finally, some future directions. So gastroparesis is a functional motility disorder. It's defined by patients with delayed stomach emptying in the absence of mechanical obstruction and the presence of chronic symptoms, including early satiety and fullness, abdominal pain and bloating, nausea and vomiting. The prevalence of gastroparesis isn't exactly known, but has been estimated to be as high as 1.8% of the general population. It is certainly more common in women, and unfortunately, its incidence is rising, associated with increased costs of healthcare and burden to our patients. In terms of etiologies, the majority of our patients are idiopathic or of unknown origin, followed by diabetic gastroparesis. And then we also see a number of drugs can cause gastroparesis and often take care of patients post-surgical gastroparesis, particularly in procedures that involve potential damage to the vagus nerve. And there's a variety of other causes that are much less common. Gastroparesis is quite a complex disorder with multiple abnormalities in stomach function that have been reported and described. And these include defective accommodation of the fundus, which is felt to possibly be related to loss of inhibitory neurons in that part of the stomach. And this leads to symptoms of early satiety. We also see abnormalities in pacemaker activity, particularly within interstitial cells at Cajal, which are responsible for this. And this can lead to gastric dysrhythmias, which are experienced as nausea. We also have seen impaired electromechanical activity, which is associated with defective antral mixing and antral hypomotility. This leads to delayed stomach emptying and experienced in patients as nausea and vomiting. And finally, we have pyloric dysfunction and antral-duodenal discoordination. And both of these can result in a functional outlet obstruction type of symptoms. And finally, we also have sensory neuropathies, which lead to visceral hypersensitivity and experience of abdominal pain. Practically, most of the pathophysiology that we have about gastroparesis, or almost all of it, has been based on deep tissue biopsy studies. And these originate from the deeper tissue of the stomach wall, the muscularis propria. And most of these studies have been done in the antral, but also in the gastric corpus, and more recently in the pylorus. And as a summary, we've learned that gastroparesis patients exhibit loss of c-KIT, which is a marker for interstitial cells at Cajal. There's also at the ultrastructure level has been reports of perineural fibrosis and altered neuronal ultrastructures. There's studies reporting loss of neuronal markers, either pan-global neuronal markers like PGP, or markers of specific neuron types like inhibitory neurons and substance P positive neurons. Other reports have noted loss of platelet-derived growth factor receptor alpha positive cells. These are a fibroblast type of cell which is electrically active and couples to ICC cells and smooth muscles. Also, there's reports showing that smooth muscle gene expression is altered, as well as the innervation to the muscle. And finally, the resident macrophage population, which is known and thought to have a basic trophic and support function to the enteric nervous system, seems to be undergoing changes, particularly with loss of CD206, which is a marker that is considered to be reflective of anti-inflammatory function. And other studies have gone on to show that there is immune dysregulation, and these reports include reduced PDGF-beta signaling and complement activation. Probably the most widespread finding in deep tissue biopsy studies is the loss of interstitial cells at Cajal. This is a representative immunostaining for these cells, and they're typically quantified by microscopy cell counts per high power field. One of an earlier studies showed that non-gastroparesis subjects actually exhibit quite a variability in the density of these cells. And when we look at gastroparesis patients, about 2/3 of these patients actually fall within the normal range, and there's a subset that has a decreased counts. And when we look at the function of the stomach in these patients, there's been no difference in 4-hour retention scintigraphy. And also in this study, there was no difference in total symptom scores between the two groups of gastroparesis patients. However, it was noted that patients with a deficit in ICC cells had increased rates of tachygastria on electrogastrography, and this was both in the fasting and the fed state. Other studies looking at ICC cells in the gastric corpus have shown similar results with patients with higher normal counts and patients with low counts. However, this was not correlated with gastric emptying scintigraphy. And another independent study from the Gastroparesis Consortium validated these findings again, with no correlation with gastric scintigraphy or total symptom scores in density of ICC cells. However, it has been reported that patients undergoing Entera gastric electric stimulation do show improved outcomes, symptom outcomes, if they have a normal complement of ICC cells. So this study showed that patients with normal complement of ICC cells had significantly greater improvement in vomiting scores, nausea scores, and total symptom scores compared to a group that has reduced ICC cells. More recently, the pylorus has been studied, and again, it's been shown that ICCs are reduced in the pylorus of gastroparesis patients. And in this case, patients with less than 10 ICCs per high power field did show increased symptom scores compared to those that have more than 10 cells per high power field. Similarly, this study also described fibrosis in the pylorus muscularis, and fibrosis was also associated with greater symptom scores. And very recently, just this past TDW, there's a poster showing that ICC depletion in the pylorus is much more frequent compared to the antrum. So more than 70% of cases had decreased ICCs in pylorus compared to 40% in the antrum. And this was much more common in idiopathic patients versus diabetic. It was also reported that pyloric fibrosis is also quite common and present in up to 70% of gastroparesis patients. And it was shown, however, that neither of these two endpoints correlated with gastric emptying. So moving on to muscularis macrophages, these are representative images of these macrophages staining for the CD206 marker. They're found both in the circular muscle as well as the myenteric plexus. However, you can see here that in neither of these locations, the abundance of these cells correlates with total symptom scores. However, it has been noted that these macrophages do have a linear correlation with the density of ICC cells. And this has led to the postulate that as these macrophages lose an anti-inflammatory phenotype and become pro-inflammatory, this generates a toxic milieu, leading to loss of the ICC cells. And so that's why we think this is a significant correlation. So in summary, based on the histology studies so far, we see that there is loss of ICC cells in the antrum, in the body and pylorus of the muscularis externa, and this seems to be a hallmark in a subset of gastroparesis patients. We don't see a correlation with stomach emptying, but ICC depletion may associate with a small subset of tachygastria patients by electrogastrography. Further, we see that pyloric ICC density may associate with improved symptoms 1 year after gastric electric stimulation with Entera. And we also see that loss and polarization of muscularis macrophages in the antrum and body correlates with the loss of ICC cells, but not with stomach emptying or symptom severity. And finally, we see that antral and pyloric fibrosis may associate with worse symptom scores. So moving on to alternate studies that do not involve routine histology. So this is a study for looking at gene expression in the smooth muscle. And the authors of this study showed that certain smooth muscle gene transcripts actually were downregulated in gastroparesis patients. And in the case of this gene MYLK1, loss of its transcript correlated with increased symptom scores. And further, the relative abundance of this transcript could differentiate different clinical subtypes of gastroparesis, including vomiting predominance, dyspepsia predominance, and regurgitation predominance patients. Moving on to other gene expression studies, there's been two groups reporting on bulk RNA-seq in the muscularis propria of the stomach. And both these studies showed that there's a significant regulation of gene expression in gastroparesis patients compared to their controls. And this is both in diabetes and idiopathic patients. And many of these genes were noted to be involved in pathways of immune dysregulation. The second, more recent study also was important because it noted that high BMI versus low BMI controls had actually quite distinct gene expression patterns, whereas in the gastroparesis cohort, the BMI didn't seem to matter that much. And then most recently, there's been a study looking at high dimensional proteomics. In this study, tissue biopsies were put through a platform that analyzed about 1,300 distinct proteins. And many of these were differentially regulated. And in particular, those that were downregulated were also found to correlate with either the symptoms of bloating or stomach emptying. And these included proteins as part of the complement activation and prostaglandin synthesis pathways. And so this study further supports at the protein level that there's immune dysregulation, and possibly some of these pathways may correlate with stomach emptying. So I've been involved since my fellowship in trying to understand whether the mucosa has any value in terms of informing diagnosis or pathophysiology of gastroparesis. And this is because the mucosa is readily available through routine endoscopy, which all of our patients undergo frequently. With our collaborators in the University of Nevada, they recently reported that in the mucosa of the antrum, there's actually a loss of enterochromaffin cells. These are enteroendocrine cells that are specialized in the production of serotonin. And the loss of these enterochromaffin cells actually also matched a reduced level of serotonin in the mucosa of the antrum. And reduced serotonin levels in the antrum had a negative correlation, which was significant to gastric emptying, both at 2 and 4 hours per scintigraphy. This was specific to the antrum. It was not observed in the fundus, the body, or the duodenum. In my personal work, I've been involved at Stanford looking at mucosal immune dysregulation, and we've reported that the mucosa of the patients in gastroparesis have increased cytokines and leukocyte infiltration. We observed this by regular histology in a small cohort of patients in the antrum. And then we went on to do flow cytometry and looking at the fundus, the body, the antrum, and the duodenum, and found that in all 3 stomach locations, there was a significant increase in leukocytes in gastroparesis compared to controls, and which was also absent in functional dyspepsia patients that had normal stomach emptying. These immune infiltrate was characterized by mast cells, macrophages, and CD4 T cells. And we noted that different subsets of macrophages were increased, including CD206 positive macrophages, as well as CD11C dendritic cells. And these myeloid cells seem to have a correlation with stomach emptying. Although this is still pilot data and it's a weak correlation, but it's promising in terms of generating further hypotheses. Looking at blood samples, we found in a panel of 62 cytokines that there were about 10 cytokines that were moderately upregulated in gastroparesis patients. And what was more informative is that many of these cytokines actually had a positive correlation to stomach emptying. And these included pro-inflammatory cytokines of the IL-1, IL-18 pathway, IL-17, and CCL2, which is a chemokine that attracts monocytes into tissues out of the bone marrow. So in summary, so far, we show that stomach biopsies have yielded very important insights into the pathophysiology of gastroparesis. And there's a very nice review that was published last year on this topic. However, up to date, biopsy research has not yet translated into clinical practice. And the reason for this, in my opinion, is that so far we've had a very modest association with disease phenotypes. And what I mean is that there's been limited evidence so far of histology endpoints that can distinguish clinical or dysmotility subtypes of gastroparesis. Furthermore, association with outcomes has been slim. There's been few longitudinal studies. And so far, the data seems to indicate that pyloric ICC density and fibrosis may correlate with Entera therapy outcomes, but this is just a minority of our patients. Another potential problem has been access to biopsies and the assays used to quantify our endpoints. Deep tissue biopsies so far have had quite limited access, typically to only medically refractory patients undergoing Entera stimulator placement, and there's been a lack of standardization in histologic quantification and analyses. In particular, counting cells per high power field can be highly operator dependent, and typically a pathologist with GI expertise is required. Finally, normative data is inadequate. We still, there's an existing controversy about whether obese subjects undergoing bariatric surgery are appropriate controls. There's likely undersampling given the limited access to tissue. We do not have an accurate map of what their differences are in different portions of the stomach. And longitudinal data is also lacking. We don't know if some of our biomarkers persist with time or become abnormal or normalize at specific phases of disease. So going forward in the future, based on the fact that we see important findings in the muscularis, including immune dysregulation and damage to the enteric nervous system and ICC cells, and then in the mucosa, there's preliminary data now showing that there might be epithelial dysregulation as well as immune dysregulation. I believe we should take an integrated approach where we can look at the immune dysregulation in all layers of the stomach wall and associate mucosal alterations with changes to the deeper layers in the muscularis, perhaps with the goal of finding biomarkers in the mucosa that reflect underlying changes in the deeper tissue. One potential approach to do this is the close and then cut technique, which is an endoscopic method of obtaining full thickness biopsies. And as a brief summary, this basically involves pulling the whole tissue into a channel, overlaying a clip which closes the stomach defect, and then clipping the full thickness specimen. A similar approach has been published, and this is for endoscopic muscularis biopsy. So this would be foregoing surgery. And this is based on exposing the muscularis first by a band ligation endoscopic mucosal resection, and then pulling up the muscularis layer as a pseudopolyp, placing the clip to close the defect, and then using band ligation to obtain a specimen. And this has been well published. This is what this looks like. This is the exposed muscularis pseudopolyp. The clip has been placed. This is what these clips can look like. Then with snare cautery, a section of full thickness muscularis tissue and serosa is removed. You can see the omentum here. And a month later, these lesions heal quite well. And the tissue for histology is of very high quality. In this study, it was reported that the mean procedure time was about 26 minutes. The mean length of resected muscularis propria was 1 centimeter. Patients had abdominal pain post-procedure, which was well managed with NSAIDs. And there was mild pain at 48 hours and, moderate pain at 48 hours and mild pain 1 week after. By 1 month, patients were back to their baseline. And of course, they were given high dose PPIs to aid the healing. It's noteworthy to mention that endoscopic ultrasound-based approaches have also been tried for this purpose of muscularis biopsies, but the yield of myenteric plexus and staining has been quite low. So I think this is a preferred tissue approach, but the adoption so far has been quite limited. And I think this is because you need advanced endoscopy expertise. And with that, I thank you, and I look forward to questions and discussion.
All right, that was a fantastic talk. Thank you so much, Andres. We'll save questions again for the end, but a great talk. And next, I'm going to introduce a very well-known speaker, Dr. Camilleri, who's got a very distinguished career, and I'll try to make his bio hopefully shorter than his talk, but there's a lot to really praise him for. So he received his MD from the University of Malta Medical School, and then completed his residency at St. Luke's Hospital. He was awarded a very prestigious British Commonwealth Scholarship to study at Hammersmith Hospital at the University of London, receiving his master's degree in physiology and medicine at the University of London, where he then became a member of the Royal College of Physicians. He was awarded further fellowship and appointment at the Mayo Clinic at Rochester, where he quickly became a professor in 5 years' time. He's received numerous honors throughout his career, which are not even barely limited to the Distinguished Investigator Award at Mayo Clinic, the Research Career Achievement Award at Mayo Clinic, Distinguished Mentor Award from the AGA, and Neurogastroenterology Section Research Mentor Award, and on the list goes. He's had numerous prestigious societal positions, including the president of the American Neurogastroenterology and Motility Society, as well as the AGA. He has over 660 peer-reviewed articles, over 290 published invited reviews, and has mentored over, I'm sure over 80 now postdoctoral fellows since starting just at Mayo Clinic. He's really redefined the understanding and the treatment of disorders of the entirety of the GI tract. But tonight, he'll be speaking specifically about antral hypomotility in high-resolution antropyloro and duodenal manometry. So thank you so much for your time. It's a pleasure to have you. And
I think you're muted, Michael.
Unmute. Can you hear me now?
Yes, we can.
You're good.
Okay, and now let me just see if I can open this. Can you see my screen?
Looks good.
Okay, well, thank you so much. And thanks, Andres, for that wonderful introduction. And so what I'm hoping to do is give you a little bit more background information, which Dr. Gottfried started to introduce the idea that the symptoms of gastroparesis do not only occur because of one pathophysiological mechanism. So I'm going to spend about half my time describing and discussing the pathophysiology of gastroparesis and focusing on antral hypomotility. And then I'm also going to introduce to you the application of high resolution manometry to more clearly understand the function of the antrum, the pylorus, and also the proximal small intestine. So I just want to remind us that as Andres mentioned, it's really important to have the phenotype well characterized when we're talking about gastroparesis. And I think the consensus is that we should do 4-hour gastric emptying scintigraphy. I just want to remind us that wireless motility capsule involves a capsule which really doesn't empty with food. It empties with the subsequent migrating motor complex, which was shown by people like Henry Parkman at Temple University. And we at Mayo have established a pretty robust gastric emptying study. We have 319 healthy controls. And as you can see, we have two very simple parameters. If the patient has more than 25% retained at 4 hours or less than 25% emptied at 2 hours, those are two very good indicators of true gastric emptying delay suggestive of gastroparesis. Also, more recent studies, we've illustrated that delayed gastric emptying, if you measure it optimally, as I mentioned here, in other words, do a 4-hour gastric emptying study with solids, not with liquids, then you will see a good correlation, or at least a statistically significant correlation with symptoms. And if you give a pro-motility agent that enhances gastric emptying, you will see a appropriate improvement in the symptoms of postprandial nausea, postprandial fullness, etc. So we published both of these, and the references are shown at the bottom of the slide. Just to remind ourselves that we really do need to study the effect of a solid meal, which has a lag time and a post-lag gastric emptying slope. And in patients who have gastroparesis, there is a prolongation of the lag time and a shallow gastric emptying slope, which means it's going to take longer to empty from the stomach. So I want to just spend a little bit of time going through the physiological derangements that retard gastric emptying. You've already heard about antral hypomotility or dysrhythmias, pylorospasm. I'm going to show you a little bit more about some data showing intestinal dysmotility can also impair gastric emptying. And finally, the important role of gastric accommodation, which may also be another potential target for treatment of patients who have gastric emptying delay. And that may actually include even surgical approaches. And we've seen, for example, and Steve might want to comment on this later, that there are actually data suggesting that sleeve gastrectomy in patients with gastroparesis sometimes enhances gastric emptying and improves patient symptoms. So let's go through some really old studies. These are data from when I was a research fellow here at Mayo Clinic. And what we did then was we looked at the relationship between antral motility and gastric emptying of solids and liquids in humans. What I'm showing you here is that the phasic pressure activity of the distal antrum determines the time it takes for stomach to start to empty, which is defined by the lag phase. So the lower the pressure activity, the longer it takes for the stomach to start emptying. And similarly, that emptying slope, which I showed you on the previous slide, the higher the motility index, the higher the slope of emptying from the stomach. Don't worry about the fact that this is a negative mark. It's the way the statistician analyzed the data. The principle is that the higher the gastric antral motility, the faster the emptying in the post-lag phase. We also did further studies at that time, a few years later, showing in detail the frequency of contractions in patients with different types of gastroparesis due to a neuropathy, a myopathy, idiopathic disorder, and compared to patients with normal motility index or with healthy controls. So the first point to make is that most patients that we see do not have myopathic diseases like scleroderma or amyloidosis. And those are usually identified by low amplitude contractions, typically less than 30 millimeters of mercury in the antrum if you do manometry. More importantly, one of the things we find really useful, and I'll be illustrating this on the high resolution manometry later, is the frequency of contractions in the 2-hour period after we give the patient a 500 kilocalorie meal. And here you see there's a pretty good cutoff compared to people who are either healthy controls with normal motility or patients who have normal motility indices, similar to those of healthy controls. If you have less than, the magic number I keep in my mind is 1 contraction per minute, because this is about 120 contractions per 2 hours. So a simple number to remember is if you have less than 1 distal antral contractions per minute in the postprandial period, that really is suggestive of antral hypomotility. Now, intestinal dysmotility also can cause impairment of gastric emptying. These are really old tracings that we did when I was a fellow. And here you have this intestinal, almost like civil war going on in the duodenum and proximal jejunum. Yes, there is a component of antral hypomotility as well, but basically we showed that both for solids and for liquids, intestinal dysmotility, especially in the presence of antral hypomotility, where you have both problems, you can see that there is a prolongation of gastric emptying of liquids and also a slowing of the slope of gastric emptying of solids. Now, at the time when I was a fellow, Fermin Mearin, who was from Spain, and my mentor, Dr. Mala Gelada, we started to notice that in the patients with diabetes in particular, who had nausea and vomiting, we often saw a paucity of distal antral contractions, which we had previously described, antral hypomotility. But we also saw pyloric contractility, which appeared to be isolated or spastic, as shown by the tonic elevation of baseline pressure. We learned how to recognize the pylorus with manometry. Pylorus is characterized by 3 or 4 parameters. The first is this tonic elevation of baseline pressure. Second, we see both antral wide tall waves and small short duration duodenal waves. And 1 centimeter distally to the pylorus is often quiescence. So this gave us a very easy way to characterize manometrically the pylorus. And what we found was about 14 out of 24 diabetic patients with recurrent nausea and vomiting also had evidence of either tonic elevation of baseline pressure or a combination of both tonic and phasic pressure activity. So this was one of the ways in which we started to identify patients who may have a problem in the pylorus. And of course, the next speaker, David, is going to give us a lot more information about this. And I'm not going to talk too much about this, David, but obviously GPOEM procedure is now being practiced quite frequently for patients who have evidence of gastroparesis or impaired gastric emptying and symptoms. And this is done by our colleagues in endoscopy and perhaps some of the people who are listening this evening. I think it's important to keep in mind that, yes, there is an improvement in symptoms. And this is a large study that came from Woon Kashag and his group at Hopkins, and it was a multi-center study. And there's improvement on several components of the gastroparesis cardinal symptom index. And again, I'm not going to talk too much about the pylorus, but only to say that it isn't everybody that responds. At 1 month, it's about 60%, but at 1 year, it's about 56% of patients will have clinical success. But there are ways in which the patients could be selected, and I'm sure that David is going to discuss the important role of EndoFLIP and also perhaps of symptoms like the cardinal symptom index as well as retention at 4 hours. Certainly, these data that come from predominantly from Hopkins suggest that a higher baseline score and more retention of food in the stomach at baseline are indicators of a positive response to GPO procedure. But I want to come back to the stomach and remind us that, in fact, accommodation may actually also alter the gastric emptying rate. So we recently published a paper in American Journal of Physiology showing that if you actually measure simultaneously gastric accommodation, we do this by injecting technetium, which, just like a Meckel's diverticulum, which contains gastric mucosa, the stomach also accumulates that technetium, and then we can use a single photon emission computed tomography or SPECT camera. We can take slices through the stomach, reconstitute the stomach, and measure it during fasting and postprandially. And this gives us a measure of accommodation. And we have validated this compared to other gold standards like the barostat measurement. So in this study, we did simultaneous measurement of gastric accommodation and gastric emptying. And we pursued this for a period of 4 hours. And what we found was that the greater the degree of gastric accommodation, the greater the postprandial gastric volume, the longer it took for the emptying of 10% of the meal, 25% of the meal, 50% of the meal, or 75% of the meal. So again, the degree to which the stomach accommodates, the stomach enlarges after the meal, may take a longer period of time for that lag period to get shortened, for the food to move from the proximal stomach, from the reservoir to the distal stomach, where the stomach antrum can then break down the food and empty it. And this is something which we, I think, still have opportunities to help patients with gastroparesis. Just as an example, macrolide prokinetics like erythromycin, clarithromycin, azithromycin, which have been shown to be quite effective in some patients in the short term for gastroparesis, they all induce a contraction of the stomach. Ghrelin agonists also produce a contraction of the proximal stomach. So that might be another approach. But I want to focus for the rest of my time on high resolution manometry. So the typical situation is we have a patient with gastric emptying delay, not only at 4 hours, but even at 6 hours, you can see there's still an enormous amount of food remaining in the stomach. And we use this multi-lumen high resolution. We have 15 sensors, which we place across the antroduodenal junction, as well as in the descending duodenum and proximal jejunum. Of course, the first thing to do is to make sure that there is no pyloric stenosis. We then put a guide wire into the small intestine, and then we push our tube over that guide wire. And here you see my 13 sensors across the antropyloro-duodenal junction and 2 sensors in the distal duodenum and proximal jejunum. So let me show you a couple of exemplars of how high resolution manometry can help us. So the meal is being ingested here, and this is the first postprandial hour. And I have 13 sensors, so even if the stomach moves, I have a very good way of making sure that I can still capture the antral phasic pressure activity and the pylorus. So just to remind you, the pylorus is characterized by a combination of antral and duodenal events, tonic elevation of baseline pressure. It usually spans 1 or 2 sensors. And as you can see in this first postprandial hour, there are virtually 5 contractions, less than 1 contraction per minute. And in the second postprandial hour, again, I'm showing you the pylorus in levels 5 and 6, and the distal antrum gives me 4 or 5 contractions in an entire hour period. So this patient has antral hypomotility. I'm also able to see, is the pylorus contraction coordinated with the distal antral contractions? And in my assessments from looking at these tracings suggests that indeed there is good antropyloro-duodenal coordination with no independent activity of the pylorus. Now contrast that picture with what I'm going to show you next. So here's a patient, here's a meal, it's completed here I have the arrow, and as you can see, the amplitude of contractions is perfectly normal. I've got a few distal antral contractions, but what I've shown you here is the marked activity of the pylorus. You see the tonic elevation of baseline pressure. You see the marked phasic pressure activity that persists even in the absence of distal antral contractions. This is a patient who I think would be well selected for a possible pyloric intervention. And we will hear more about this from David. Second postprandial hour, it actually persists. The antral contractility fades away, the pylorus continues to contract. So my point is that I think that using high-resolution antropyloro duodenal manometry, we should be able to identify who might be the best candidates to treat the antral hypomotility or candidates to treat the pyloric dysfunction. Also, point mentioned by Andres is, let's keep in mind that pyloric phasic pressure activity is stimulated by opioids. And this is a nice review that Kent Sanders wrote. I was with him, and shows that the opiates also stimulate the pylorus. So let's make sure we exclude iatrogenic disease. So in summary, I'd like to leave you with two main messages. First of all, are there other mechanisms that result in similar symptoms? We should not only think of the antrum and the pylorus, but also possibly the accommodation response of the stomach. Should we be offering GPOM as a treatment for gastroparesis? I think the answer to that question is yes, but my plea is that we be a little bit more selective. At Mayo, our practice is evolving. We repeat the gastric emptying study at Mayo Clinic. We exclude iatrogenic disease. We exclude rectal evacuation disorder because we see so many patients referred for gastroparesis symptoms who turn out to have constipation and rectal evacuation disorder. Before we pursue a GPOM, we are quite interested in continuing to do our high-resolution antropyloro duodenal manometry to help us understand who might be the best candidates. We are, of course, performing EndoFLIP of the pylorus, and David, we're looking forward to your comments and your recommendations. And then I believe that we should, in the future, individualize treatment to pathophysiology. So thank you once again for the invitation, and I turn over the podium to you.
What a fantastic talk. Thank you again so much. Moving on to our next speaker, as was alluded to, we have David Kunkel from UCSD, who he completed his residency at Cedars-Sinai in LA. This is followed by a fellowship at UCLA. He has received specialized training in motility diagnostics, including manometry, gastric emptying, smart pill, Celesta injections, and biofeedback. He then became faculty at UCSD, where he now helps direct the GI motility and physiology program. His research interests include gastroparesis, short bowel syndrome, IBS, and biofeedback. In 2013, he was the recipient of the American Neurogastroenterology and Motility Society Clinical Training Award in Motility, allowing him to further his studies and training. Tonight, he will be discussing EndoFLIP as a diagnostic utility for gastroparesis diagnosis. So, David, take it away.
Thanks very much. Let me share screen and maximize. Well, it's a pleasure to be speaking about EndoFLIP of the pylorus, and on the heels of wonderful presentations by Andres and Michael Camilleri. I am going to be hoping to accomplish, oh, let's see, there's a little bit of a lag here. Okay, yeah. So we're going to talk about some of the dilemmas in gastroparesis and the pylorus. And then I do want to talk extensively about how to actually perform FLIP of the pylorus, which as a preview is much more challenging than FLIP of the esophagus. And then we'll review of some of the importance of the data and what exactly are normal values for FLIP of the pylorus. So first, I want to start with humility, which is, I think, touched on by both Andres and Michael, the origin of symptoms in gastroparesis. We have to be humble about this because it's not a one-to-one connection between any particular biomarker and the symptoms that our patients come to us with. And just to give you sort of the 30,000 feet view about 80% of patients with gastroparesis also fulfill the symptom-based criteria for functional dyspepsia. And 30% of patients with functional dyspepsia do meet the criteria for gastroparesis. So these disorders probably are on a spectrum. 6 of the 9 questions on the gastroparesis cardinal symptom index record common symptoms of functional dyspepsia. So we have to keep this in mind, which is this symptom-based entity of functional dyspepsia has some overlap with gastroparesis, which is defined by this biomarker of delayed gastric emptying. And what is the significance of delayed gastric emptying and symptom severity? This is a very important slide because it shows the data from the NIH Gastroparesis Consortium, and specifically that there's no real connection between how much solid food retention was noticed at 4 hours and how severe these patients' symptoms are. And this is significant because the consortium, of course, is West Coast, East Coast, and they've harmonized how they perform gastric emptying. So the scintigraphy is done in the same way across all sites. When you look at the US or in the world, scintigraphy is done a million different ways. So this data really tells us that it's not a one-to-one connection, symptoms and gastric stasis. So understandably, there's interest in looking at other biomarkers. You know, Michael has outlined really elegantly antral hypomotility as an important biomarker. Andres reviewed with you histologic findings. And I'm going to talk about the pylorus. One more point, though, before I focus on the pylorus. I think this is a really important study that came out earlier this year, and it showed that about 1,000 patients who came in with symptoms of either gastroparesis or functional dyspepsia, after about a year, 40% of the patients with gastroparesis switched over to functional dyspepsia, meaning their gastric emptying study normalized. And about 40% of the functional dyspepsia patients on a repeat study were now classified as gastroparesis. So it's a fluid, labile, imperfect biomarker. And even some of these stomach biopsies showing loss of interstitial cells of Cajal, loss of these protective CD206 macrophages, they were similar across the GP and functional dyspepsia groups. So it sounds like I'm harping on this, but this is the humility that we have to bring to these patients, which is we have imperfect biomarkers. We're not able to explain all the symptoms. And as Michael Camilleri was stating, we're in the era of personalized medicine and trying to identify new biomarkers that will predict treatment response. So the pylorus, this is something that has been around for a long time. All of us in medical school learn about the 6-week-old male infant that is regurgitating. And so we all know pyloric stenosis causes problems. But stenosis isn't the only thing that can go wrong at the pylorus. Michael Camilleri told you about the other entity, pylorospasm. And there is nuance there. These are different things. And if you're going to try and assess them, you might get different numbers. You might need different tools. So the pylorus is old and established. And so intervening on it in adults is not a new idea. And there have been 2 randomized control trials, one in patients with diabetic gastroparesis, the other in idiopathic gastroparesis patients. And in neither trial did Botox lead to any benefit over, a sham injection or placebo. And so these 2 studies hang over the field of pyloric interventions. And a lot of us have said, well, listen, the lesson here may be that the pylorus is relevant only for a subset of patients, and it's not relevant for all comers. And thus, we need tools that help us understand who may benefit from a pyloric intervention. Well, in comes this very fancy tool called the EndoFLIP. And this is a catheter with a balloon on it. And the balloon inflates. And then you can see this is sort of a bird's eye view of it traversing across Mr. Pylorus there. This is attached to two machines. I have here the newer machine and the original machine, and they provide information on geometry, or in this case, distensibility, stretchability of anything, including the pylorus that you want to measure. It gets a little complicated though. So if you said, okay, I want to, just start tomorrow, I want to start measuring a flip of the pylorus. Well, let me give you some background data. There are two different flip catheters. The primary difference is the 322 is twice as long as the 325. Same number of sensors, but they're spaced 1 centimeter apart with the 322, only 5 millimeters apart with the 325. And they're on the same 7 French shaft. 325 goes up to 50 ml, 322 goes up to 70 ml. And so, this is important. What catheter are you using? What measurements are you taking? Now, why do we have, why might we want arrays of different lengths? Well, a denser array is better for a shorter area of interest, and a longer array allows the possibility for assessing contractility or contractile response, in this case, potentially in the antrum. But there's a lot that can go wrong with the flip, especially if you're going to look at the pylorus. The pylorus is not fixed like the esophagus. The pylorus is floppy, it moves around. If your patient is receiving anesthesia, all kinds of anesthetics can impact the status of gut smooth muscle. There's gas sevoflurane, ketamine, glycopyrrolate, all have big impacts on the numbers that you're going to be measuring. And none of us are the ones who are controlling the anesthesia. So there has to be a dialogue. Even if they give sucks and want to intubate a patient because they see gastroparesis in the chart, that's going to need to be reversed. If you're in the OR and the abdomen is insufflated, that can affect distensibility. Catheter placement. So it's much easier to get your catheter across the pylorus if you go through the scope. And the wide diameter channel endoscope can handle EndoFLIP going through it if you just remove the cap. You can go alongside the scope, but it's going to take some skill, maybe some work to get the catheter across the duodenal sweep so that you can slowly withdraw it in position across the pylorus. And then you have decisions to make in terms of your filter settings. The EndoFLIP gives you a number, but you need to understand, is that a weighted average, a standard average, or do you have filtering turned off? So this sounds complicated. It is complicated, and I want to give you some pictures from a case. So here's a gastroparetic. We see retained food. Here's the catheter. and this is the 325, the 8-centimeter catheter, which frankly is a little bit too long because the first portion of the duodenum, may not necessarily accommodate 4 centimeters of balloon being lodged in there. And you want your catheter traversing the pylorus, and traditionally you'd like it positioned in the middle. So look at this image, reflect on the position of the balloon. Look at this image. Now image number 3. See how there's less droop here? So the catheter is sort of taut here. Now there's less droop and it's sagging a bit. Guess what? Your distensibility is different at all 3 of these measurements in the pylorus. This is not as straightforward as the esophagogastric junction. Now the catheter is positioned straight, dead on. This is the position that I'd like to have it. And here you can see it's swallowed into the duodenum and it's taut again. So you don't want to get measurements from this position. Well, this is the endoscopic view. What does it look like on the machine? On the EndoFLIP. This is not a good image, all right? I'm gonna just get to the point here. You see how there are 2 narrowings? This is when this EndoFLIP balloon was sucked into the duodenum. So in fact, what you're measuring is this turn at the duodenal sweep up top, and then the pylorus is down here. This is 8 centimeters long. So what's going on at one end does have implications on what you're measuring elsewhere. The view that you want is right here. This is pylorus right here in the middle. Nothing else is squeezing on the balloon. It's midline. The anesthesiologist hasn't blown up the whole experiment giving gas or ketamine or glycopyrrolate. These are numbers that you can sort of hang your hat on, so to speak. The largest series of patients was from Bill Snape up in Northern California. And this was 114 patients who showed up with nausea and vomiting. And they all underwent gastric emptying and they all underwent EndoFLIP. And you can see the folks who had massive delay, the distensibility index was 8 plus or minus 1. The normals and mild delay were around 12 to 13. So here's some important numbers to sort of bear in mind as you go to interpret things. And you'll note, the pylorus is much looser than the esophagogastric junction. What does this data mean? Well, I'm going to present, quickly 2 abstracts from DDW this past year concerning prediction of treatment response. So from the consortium, they measured EndoFLIP at baseline, and then GPOEM was performed, and they measured EndoFLIP after GPOEM. And they used the 50 ml diameter, okay? And so that means they're using the 325 balloon. And you can see what's really interesting about this data to me, since it was done at a different center, is the distensibility of folks who responded to the GPOEM was at baseline higher, not lower, higher. So patients who had increased distensibility did better with the GPOEM. Interesting, right? Not necessarily what you would predict. Meanwhile, so gastroparesis, meanwhile, at our center, totally apart, we used the EndoFLIP to try and predict treatment response to Botox. And we looked at both diabetic, idiopathic gastroparetics and separated them. And what we found was a higher baseline distensibility in idiopathic gastroparesis predicted a favorable response to Botox. So two centers, two different pyloric interventions, but both with the same finding that a higher distensibility was favorable for a pyloric intervention. So this is interesting stuff. There's more to tell about this story than just pyloric stenosis. This idea of pylorospasm, I think, is important to keep in mind. And with that, I will summarize that pyloric dysfunction may well be an important factor in a subset of patients with GP. EndoFLIP provides a quantitative measure, but it's much more difficult than taking your measurement at the esophagogastric junction. And in particular, prediction of treatment response appears to be a very important role for EndoFLIP. Thanks very much for your attention.
All right, David, thanks so much. That was a fantastic talk. So we'll move on to our Q&A. Thank you again to our three speakers for some fantastic talks. I'll throw in the questions kind of in order of our speakers, starting with the audience members here. So Andres, one of the questions that came up was that you've shown some studies mentioning mast cells. In your review, are eosinophils an issue? Have they been seen? Is there an interest in eosinophilic gastritis in some of the work that either you've done or that you've researched?
So yes, unfortunately, in our own study using flow cytometry, we did not have markers for eosinophils, so we could not quantify them. But as Dr. Parkman mentions, yes, eosinophilic gastritis has been recently reported on in a quite a large cohort of patients with symptoms of gastroparesis, but this cohort did not have gastric emptying data, so we do not know how specific it is or whether it is occurring in gastroparesis. It is reported to be known in functional dyspepsia patients in the duodenum, but these findings show a significant number of patients with eosinophilia in the gastric mucosa. So there's a lot of interest to look at that.
So I had a couple kind of simple practical questions for you. When we talk about measuring ICC counts on biopsy, is that something that a community-based pathologist can do? Does it require special standing? Is this something that can be applied outside of an academic center? And kind of a similar question is, from a pathology standpoint, what criteria is being used to define pyloric fibrosis?
These are good questions. I am not a GI pathologist, as a disclaimer, but detection of ICC cells is quite straightforward. You can do it with regular immunohistochemistry. Antibodies that are commercially available are very good and sensitive with no background. The challenge comes in processing the tissue. So the plane at which the tissue is sectioned plays a big role in how you interpret your counts. And also ICC cells can be in or out of the plane of the section. So pathologists usually are more experienced in determining what constitutes a cell versus a staining artifact. So those are just a couple of nuances. But overall, I would say that ICC histology can be done outside of specialized labs, but care should be taken to standardize the orientation of the tissue, the sectioning, and other parameters.
Thank you. So kind of a similar theme of how to extrapolate a lot of this information to the community kind of non-academic center, because we know there's a lot of gastroparesis patients, so it's rare. There are a lot of patients, and not all of them end up necessarily at an academic center. So this next question I have is for Dr. Camilleri, which is, I'm a surgeon. I also do some basic endoscopy, but obviously pyloric interventions sound great, G-poems, pyloroplasty, pyloromyotomy. But as we say, separating pyloric pathology from antral motility or antral pathology as well is important in understanding this disease process. But is this something that can practically, from a diagnostic standpoint at least, be practically applied to the community setting who may not have the same tools such as EndoFLIP technology?
Yeah, it's a great, very practical question. Heineke-Mikulic's pyloroplasty endoscopic or laparoscopic pyloroplasty is probably much more accessible in the community than some of the techniques that we've talked about today. And so I can perfectly understand the question, Steve. At the end of the day, I think it behooves us, at least in the academic practices, to actually prove that these treatments which can be applied in the community, such as pyloromyotomy endoscopically or laparoscopically, that they actually do improve the patients, are associated with success. I'll point out that there hasn't been up to now even one sham-controlled GPOM study. And again, in full disclosure, Hopkins and Mayo Clinic have recently been funded by the NIH to do such a clinical trial. So we're hoping to be able to provide an answer to that question. And then, we're also at the same time trying to see whether the additional measurements that we have mentioned today, like duodenal manometry, EndoFLIP, actually is necessary to predict responsiveness to treatment. So we're hoping that over the next few years, we'll be able to answer the questions, to be able to provide feedback to practitioners in order to proceed with the interventions. Whatever it is, I think it's really important, if I may, just take 30 more seconds, to do a gastric emptying study that is optimal. And the correlation, the lack of correlation, which was seen on that beautiful picture, which David showed, I could quite honestly criticize, because the normal values for an egg beta's meal is probably not 10%. And there will be data that are currently under review from another center, not Mayo Clinic, showing that that 10% value needs to be revised. And if you actually look at the parameter we use at Mayo, which is 25%, the correlation becomes one heck of a lot better with symptoms if you have a robust gastric emptying measurement that shows true impairment of gastric emptying.
I'm glad you brought that up, and as a surgeon who's also in the community, I'm glad you brought up the idea of gastric emptying study, because I've had a handful of patients where, and this will formulate into a question, I promise, where one of two issues happens, and it's a little frustrating for me, is one, they'll do a formal gastric emptying study, appropriately protocoled, but they'll stop at 2 hours, or two, we get the patient with the egg allergy, and they'll convert it over to some sort of an oatmeal type study, and again, cut it off at 1 or 2 hours. So, and then the radiologist will say, well, this is kind of all we can do. What do you do with those patients? Again, kind of in the subset of community institutions where gastric emptying studies are one tool.
Well, unfortunately, if patients have an egg allergy, you're stuck. But if patients don't have an egg allergy, you should be doing a proper gastric emptying study that goes on for at least 4 hours, and then use a parameter that truly identifies delayed gastric emptying. And I think that number should be probably closer to 23% rather than the 10% that's currently being used. And that's really based on preliminary data. And I know Henry Parkman is on the in the chat room, certainly, and the data I'm citing is really from his laboratory.
Thank you for that. So a couple of questions, technical standpoint about EndoFLIP for David is, one question that came up is there a way to station the antropyloro duodenal catheter such that the pylorus is recording in the same channel rather than looking at different parts of the catheter?
David, I think that one may be meant for me.
Yeah,
apologies.
Exactly.
So yeah, I mean, the Australians do colonic motility measurements, and they anchor with a clip they anchor the catheter in the cecum with a clip. So that's a possibility, to incorporate a clip into the catheter to hold it close to the antrum. We haven't done that because, quite honestly, if you've got 13 sensors, we've been very much capable of picking up the antrum in all cases. And I don't know what artifact will be introduced by that clip. Does it actually impair the function of the stomach? I don't know the answer, but it's a great question.
All right, well, sorry for sending that question the wrong way. Here's another question for you, David. You just mentioned a couple of times the concern of anesthesia, different medications, or especially the use of EndoFLIP during surgery and pneumoperitoneum. Let's just start with the most basic situation. Doing diagnostic outpatient endoscopy with EndoFLIP. What do you tell your anesthesiologist? What's your protocol? What drugs are okay? What drugs are not okay? In an ideal world, what do you tell them to do and not do?
Yeah, I think the key ideally is to just use propofol, and fortunately that is the preferred agent. Ketamine in the adult world is not as popular, and they don't need to use sevoflurane. They don't need to give glycopyrrolate. So stick with your good, tried and true Michael Jackson style propofol, and that's not going to interfere with the measurements that we're taking. Now, a lot of us believe, nevertheless, that a deeper sedation does affect contractility. That's traditionally more of a concern in the esophagus. I think it remains to be proven if EndoFLIP is really a useful tool for antral contractility. Really, with FLIP, we're more interested, at least right now, in just the distensibility of the pylorus, and we don't have any suggestion that propofol is interfering with that. Although, to be fair, you'd have to do trials in healthy controls where they are getting, Versed fentanyl versus propofol to really prove that. But I think that would be sort of the conversation I'd have with the anesthesiologist, and that I do have.
And in your own practice, whether you perform endoscopic or GPOEMs, GPOPs, obviously presumably under some sort of level of anesthesia, or your colleagues who's doing these procedures, does this affect your measurements if your institution is doing intraoperative or intraprocedural EndoFLIP during GPOEMs, GPOPs?
Yeah, we don't do it during the actual GPOEM. We get a measurement before, a measurement after. So that's sort of our approach. I imagine, you could get one in real time, but as Michael said, currently GPOEM is sort of the realm of our interventional endoscopists, and I guess, to agree, our foregut surgeons, whereas EndoFLIP is usually more in the motility, GI motility providers armamentarium. So that's still primarily our realm.
Yeah, I would agree. I would say that most of the intraoperative usages of EndoFLIP, for the most part, is at the GE junction, achalasia, fundoplication. So I was just curious if you guys have used it for the pylorus. So while I have you on the line, one of the questions popped up was, can you discuss the use of EndoFLIP interpretation specifically for antral motility as separated from pyloric?
I think we need more data on that. There's been some preliminary type work. I don't feel comfortable saying we know exactly what normal motility is, especially when it can be impacted by whether the stomach is insufflated, whether there's retained debris in the stomach. There's so many things that affect antral motility. I don't think we can say that EndoFLIP data on this is definitive to separate health from disease. again, you have to appreciate we're coming sort of from a frozen tundra where anything would be an improvement. Traditionally, an endoscopist would label someone as having pyloric stenosis just based on whether it was hard for them with their scope to get through into the duodenum, which is certainly not a very quantitative, reproducible biomarker. So we have an improvement, but it's certainly not perfect, and I don't think that it's ready for prime time in terms of antral contractility. That's where the technology Michael was describing is much more apt for that.
Thank you. Andres, I did have a question with some of the studies that you showed with increased leukocytosis and cytokines that have been found in patients with delayed gastric emptying. Do you know if there's any current or future studies or plans for future translational research to see if there's any role in anti-inflammatory medications or anti-inflammatory targets from a basic science standpoint as treatment for gastroparesis or delayed gastric emptying?
That's a great question, Steve. I am not aware of any trials or clinical translational work looking specifically at anti-inflammatories. Yeah, it's an open question. I personally, I've been trying to get funded to pursue more studies as what I've reported, and I'm hoping to do that. And perhaps down the line, when we have a better understanding of what's causing the leukocytosis, is, it's like a chicken and the egg type of problem. Is it gastric stasis, which is irritating the mucosa and causing this kind of microscopic gastritis, or is it this microscopic gastritis which is leading to immune dysregulation deeper down in the muscle layer? We really don't know. What I will say in our small pilot cohort of patients is that PPI use actually was associated with increased leukocytosis in the mucosa compared to those that were not on PPI. And this was specific to the gastroparesis cohort, not our control group. So drugs certainly play a role. That's the only kind of drug association that I'm aware of at this time.
Yeah, it almost seems like both the inflammation, anti-inflammatory question, as well as PPI use, both seem like chicken and egg type questions. So definitely a lot to still study. While I'm pestering you for questions, just a quick practical question. You described a couple endoscopic techniques for what would be constituted as full thickness biopsies. I was just curious what your or the traditional techniques are for what's considered deep tissue biopsies. From a technique standpoint, is it just jumbo forceps, more tissue, or what's the technique between deep tissue before you get to full thickness?
Well, at least in most of the reported studies of deep tissue biopsies, the vast majority came from surgical procedures where patients were undergoing an entera gastric electric stimulator. There are some small series showing the use of as I showed, endoscopic deep mucosal resections, but that's kind of like, and in terms of controls, we're getting tissue from bariatric procedures, which are surgical as well. So I don't know. I haven't seen reports of docs trying to get muscularis tissue using like a biopsy on biopsy approach with large forceps. I think most endoscopists would be concerned about the risk of perforating the stomach, even though it is quite thick, but that kind of blind approach I have not seen in the literature.
Yeah, it's definitely interesting because you think from a surgical biopsy is going to be from serosa inwards towards mucosa, and then an endoscopic is mucosa outward towards serosa. So the comparison between the two, but obviously the idea of a full thickness biopsy would obviously kind of clarify the discrepancy between the two. Thank you very much. Another question that came up for Dr. Camilleri was in patients who have total, presumably the question is total intestinal dysmotility in addition to delayed gastric emptying or gastroparesis, what your kind of treatment algorithm or treatment approach is to gastroparesis in this setting of total gut.
So, I mean, the first thing to keep in mind always is make sure the patient doesn't have a rectal evacuation disorder with constipation, because you've got to get that under control. The second thing to think of is there, you know, something like an opiate or an anticholinergic antidepressant in the background. Now, if you've excluded those, then what we typically do is we use a cholinergic agonist or a drug that stimulates the excitatory neurons. Prucalopride is approved by the FDA for treatment of constipation. There is a clinical study from Jan Tak suggesting that it accelerates gastric emptying as well in idiopathic gastroparesis. So that's usually our first drug. Unfortunately, often it's unaffordable for the patient, or the insurance does not permit it. So our backup drug is to use pyridostigmine or mestinon, an anticholinesterase inhibitor, typically at a dose of 60 milligrams 3 times a day before meals. And that usually has an ability to help the stomach empty, the small bowel transit, and colonic transit.
Thank you very much for that response. So we're approaching almost an hour and a half, so I do want to kind of wrap it up with one last question, and selfishly it's a question of mine, but I think the whole idea of the American Foregut Society is to bring both surgeons and gastroenterologists together who are practicing, studying, and treating in this field. So I have a question that hopefully bridges the gap a little bit onto the surgical side of things. And this question was alluded to during one of the talks, which is emerging data about specifically sleeve gastrectomy as a treatment. And we're going to again have a treatment conversation webinar next month. But the data for a sleeve gastrectomy for gastroparesis, it's fair. It's not the most robust data in the world, but as also a bariatric surgeon who does perform pre-bariatric surgery endoscopy, I do see a fair amount of patients who never were diagnosed, and we find out they do have true gastroparesis going into a bariatric surgery. So obviously, we only do so many different bariatric procedures. We have the sleeve, we have the bypass, and the duodenal switch. Most of the data for gastroparesis has been in the sleeve realm. It's been pretty limited, and it's not the most robust data. But do any of the panelists have any insights, thoughts, or just anecdotes or what have you about patients who are in either obesity or in the bariatric program, kind of what pathway to send them on for gastroparesis patients who are seeking out bariatric surgery or in the setting of obesity?
So I'm old enough to remember surgeons like Dr. Keith Kelly and Dr. Michael Sarr here at Mayo Clinic, who used to operate on patients with post-vagotomy or Billroth 1 gastrectomy gastroparesis. And the treatment of choice for those patients used to be to do a Roux-en-Y gastric bypass, reduce the size of the gastric remnant, and do a short limb, 25 centimeter Roux limb. And of course, if the patient is obese, then there is also an opportunity to lengthen that Roux limb. And I'll defer to you on the details. But I also think that our recent accommodation study does suggest that there may be some benefit in considering a sleeve gastrectomy to reduce that prolonged lag time, get the food down to the distal part of the stomach where the antrum can triturate it and empty it. So that's how I'm thinking, and I'm also kind of backed up by the clinical experience of some wonderful gastric surgeons that we've had here.
Do any other panelists have any? Go ahead. Yeah.
Steve, it's not a go-to, but we have sent folks for sleeve where there was BMI elevation and medical management was coming up short. Those patients in particular, it's helpful to, in my experience, get a wireless motility capsule study, really just to make sure their colon is working and that we're not getting burned, as Michael alluded to, by, constipation and emptying problems, since absolutely I would be doing all the foregut surgeons at UC San Diego a disservice by sending someone for a sleeve where I've missed a colon problem. So if they have a normal wireless motility capsule, or if you don't have access to then just standard radio opaque markers, That's an important part of that trajectory if their ultimately sleeve is one of the Hail Mary options for them.
Yeah, that's a great point. I think, there is a lot of research study that even more of a Hail Mary than that, it's people doing total gastrectomies, but that's obviously the true end all be all. But one of the interesting concepts for me as a surgeon is the idea of a Roux-en-Y gastric bypass compared to a sleeve. The treatment, you're leaving the patient with very different stomachs, right? The sleeve, you're still leaving them with their pylorus and their antrum. The gastric bypass, they're not part of the system anymore. So it's very interesting work. So again, we're rounding out about an hour and a half. These were some fantastic talks with some fantastic speakers. I have to thank all three of you so much for your time. It's been an honor to have you so much. The American Foregut Society thanks you. We, again, are a society that is really all about collaboration between surgeons and gastroenterologists who are really foregut nerds who love the diagnosis, the physiology, the treatment. It's been a pleasure to work with everybody. This has been our diagnostic session on gastroparesis. Next month, look out please for our therapeutic session. We have a couple other sessions coming up by the end of the year to next tackle Barrett's esophagus and early esophageal cancer. So again, to all my speakers, thank you so much for your time. It's been a pleasure. This will be recorded. It'll be available on our website and our YouTube channel. So please feel free to share it with anybody and everybody. So again, thank you speakers so much for your time.
Thank you very much.
Thank you very much.
Thank you.